I want to introduce today's speaker. So today with us, we have Dr. Eric Storch. He is professor and vice chair of psychiatry and behavior science at Baylor College of Medicine in Houston, Texas. He is also the lead investigator on the Brittle Bone Disorders Consortium for the OI Wellness Study. Dr. Storch, thank you so much for being here.
Thank you everyone for joining and listening to me. I have teenage kids and I can appreciate that that's a relative miracle for at least them. So I do appreciate this. Now, today I want to share some slides and just talk for a little bit about some of the work we've been doing and some of the findings that have emerged thus far, and then just sort of open it up for thoughts, questions, reflections, all that good stuff. Okay, so let's see. All right, I think we got this.
We are seeing if you can go to your display settings and switch the displays.
Oh my gosh, I did it the total opposite side. Okay, you see it okay?
One sec sometimes takes a second to update.
Let's see. You would think after how many years I would have figured this one out. How about this now?
If you can press we're seeing like the editing view of PowerPoint.
Oh my Lord. Resume slideshow. Nope. Man, Michael, this is embarrassing, buddy.
Oh, it is. Oh, I've been there. Totally understand.
Okay. All right. This third time is gonna be the charm. Okay. So I think you see my left side, right?
We are still seeing it in the editing view, but you know what? I think for the sake of time, if you
Look at
want
this.
to even present it like that. Oh,
All right, we
there
golden
it is.
now?
There it is.
It was gonna happen.
Okay.
Okay. All right, perfect.
Perfect. Thank
So So this was sort of a funny story, and I really think about the way that life kind of works in fun and mysterious ways. So one of my first areas of work was working with young people who had various forms of chronic illnesses and sometimes really rare diseases. For example, a condition called Barth syndrome. So my career took this sort of pathway, and I began focusing on things like anxiety disorders, obsessive compulsive disorder, and life was good. And then I get to Baylor, learn that cowboy boots are like high heels for men and give you a solid 2 inches more. And all of a sudden, I get this email from a couple colleagues, Dr. Sutton and Dr. Lee, who said, we want to put in this resubmission focused on behavioral health. And NIH actually said, hey, why don't you go talk to Storch on this one? So they did. Together with a whole bunch of us, we came up with a couple ideas. And NIH, to their credit, said, hey, we like this. And so that brought about this focus, this kind of concept of investigating what I think many people have really appreciated. Now, in the selfish perspective, it allowed me to kind of get back to that first love of working with people who are going through something on a health realm and integrate that psych side together with the physical health side. And so, as we started building out our literature search, what we quickly realized was that there was very little that had been done. And what we also were realizing is that if we assumed that we knew, we would be assuming incorrectly. And the best way to figure out stuff is just to talk to people. And not only talk to people, get ideas, and then sort of move from there. And so this collectively resulted in us receiving a grant that went through the last few years of the BBDC uh, uh, rare disease grant, focusing on exactly that. So the first is doing a number of interviews, hopefully with some people on this call, whether with folks who are clinicians, people who were adults with OI, caregivers of someone with OI, and just hearing perspectives. Then we also wanted to integrate a few behavioral health measures in the longitudinal study to try to understand different trajectories as well as kind of buffering variables. And then from there, develop a bit more of a quantitative approach to kind of figuring out how do we want to think about some of the behavioral health constructs experienced among folks with OI. And we're in that space right now. So the one of the parts that was most fun at the start was exactly this. It was interviewing caregivers, interviewing adults, kids who were hysterical, and then the clinicians. The kids were funny because they were just like everything's cool, and the parents would sometimes get on. They're like, no, 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 like I have to pull them back, and but the idea was to really get everyone's perspective and sort of move from there in terms of understanding different facets. So we've published or are close to publishing a couple additional papers that really hit on these topics. And I'm quickly going to go through each of these and sort of where we are, and then the key findings. Now, the first one that we did with I always love this with Connor Rourke, who was one of my coordinators, who's now midway through his medical training in New York, and someone that we got excited about OI through this, and hopefully in a few years will be a doc working in this space. But this paper really spoke about that issue of recovery and then the thereafter. So the recovery often being limiting in terms of ability to get out and about, connect with others, do the things that people love. And then the fear of fractures is sort of a common one. We've has done some work in the past with cancer, and it was actually struck me as very similar. This fear of recurrence that a lot of individuals with cancer experience post-intervention was something that a lot of families, a lot of individuals described, is this concern about, can this happen again? And if so, when is it going to happen? Now, a second piece our second paper we published was focused on pain and pain management among adults. And so some of the findings weren't at all surprising. Pain for many is a significant issue. Management is a significant issue. But I think some of the other pieces that came up was really a lack of awareness, particularly about the nuanced aspects of pain, as well as management strategies, and coming into those, sort of coming into that with an open mind, as opposed to, I think, what some docs in community practice may think about when individuals are experiencing pain, is concern about is there any sort of abuse or so on. And so this was something many people described as their providers outside of the OI experts really didn't have a good understanding of some of these matters. And so as a result of that, the treatment inaccessibility was described, stigmatization was also described. Now, this paper is about, I'm sorry, was actually just accepted. We have another one that's about to be accepted. And so also one of the things that wasn't particularly surprising is that the individuals with whom we spoke were incredibly resilient, were incredibly funny and fun, had different ways of dealing with things that were remarkably adaptive, both at an individual level, but a sort of community level. The OIF was described often. Peer relationships on a one-to-one level, or within family members or friends or community, were also widely described. And these were all sort of adaptive components that help people buffer against various stressors that happen in life, whether it's OI related or just the vicissitudes of life that we all end up experiencing. Now we have, I always laugh at this paper. This one is about to be accepted. The editor on the last go around said that we use the word "the" too often, which I think I've published a few papers, and that's the only time I've ever had anyone say that. So we're just like, all right, we'll take the word "the" out, and I think they'll be happy. So we're waiting on that revision, but not surprisingly as well, is that there were different issues with kids. Um, this is going to be a shocker that school was really a challenging one. And a lot of schools were just hard to work with. They didn't understand it, or they did, but they may not have been equipped to just manage needs of individual children. Um, I think one stressor or lack of stressor, depending on the nature of the school, was when you had a school that was just responsive and open, non-judgmental, and received information and tried their best. Even if they couldn't sort of do it successfully or manage, it was that effort and that partnership that was really a massive, massive factor in parents feeling heard and supported. I described how funny kids were, and at the same time a challenge. When you had a kid who loved, one of our kids loved football, but he couldn't play football, and so he ended up being team manager, which was great. But he always sort of looked on the field with a little bit of envy to his peers, and so while it was good, it wasn't the same. And so with that, I always think about the way of personalizing life, and sort of owning the good and the bad and the ugly, but trying to be flexible in managing aspects. One of the other things parents ended up describing is some of their concern in engaging with providers that don't really have an understanding of OI in terms of aspects like pain management, or in the presence of frequent fractures, misinterpretation of what that meant, as potentially reflecting abuse or something aggressive as opposed to the nature of the condition. Now this is oh, sorry. This one is also in revision. Um, and so a couple, well, we've actually hit a number of these points already. Like with our adults, it was the post-injury that was most difficult for our kids, and as well as the parents, not surprisingly, who I think, as one parent described it, they described their child as their heart walking out the door, as they're sort of watching them go. And I think that was something that many parents noted as difficult with their little ones. And then with regards to facilitators and barriers of care, this is one that we're currently working on. And a lot of things also are sort of intuitive, which was one of the neat aspects of our qualitative work. One of the main facilitators that we can appreciate from COVID was the acceptance of telehealth, which just took a massive burden off things, both from a physical health but mental health standpoint. The barriers are also not surprising. We've talked about pain management and accessibility of that. I think the other is specialty access to specialty providers across whatever health domain. Many people describe that. And then with the young people, that also was an issue. And then on the behavioral health side, really having people who have kind of applied their trade in the space. I think we're fortunate to have a couple, at least one on this call, who've really done excellent work here. But it speaks to the need to get out additional information on what some of the nuances and considerations might be. And then this is one that we're waiting on the acceptance. We just resubmitted a few weeks ago, and the revisions look like, well, the reviews look like my mom reviewed it. It was very positive. But I think, again, speaking of some of the positives and challenges, positives being the support from peers, the support from the foundation, the community at large, and knowing that there are providers and researchers who are really focused on this one space. I think the con, or some of the challenges also related to things like diagnosis and the ambiguity around those initial stages if that diagnosis took place a little bit later in life. And then one of the other points of this last bullet was how things differ throughout life, whether you have a little one, or that little one becomes a little bit bigger and tests things, or an adolescent and thereafter. So it's one of these pieces where parents were describing never sort of being at rest, or at least at rest for any extended period of time. There's always something changing, and curveballs that could come with that. Now, we have since moved or had since moved into a perspective study. And One of the things that I'm excited about this is if we're able to, God willing, continue going, is be able to look at longitudinal relationships among variables, as well as buffering factors. And I think that perspective data really gives us a good idea of, why not just A is related to B, but why that is and for whom. And so that's what we're really excited about. I'm going to acknowledge I'm a soccer fan. I'm getting ready for the World Cup, and so we always. I don't think this works for everyone else, but I always think about recruitment as like the World Cup. And so here's where we are. I guess UNMC is sort of like Argentina right now, but. US is somewhere, Baylor's somewhere in the mix, right in the middle. But uh, again, this is that work in progress. And so we have closing in on 100 people who've finished their initial assessment. And I think that key is going to be time points 2 and 3, which we would be able to get at with additional support through NIH. Now, the phase 3 piece is where we're at right now broadly as we again wrap up those qualitative interviews or the data analysis. But AIM 3 was all about listening to what everyone was saying. And when we wrote the grant, it was kind of interesting because we're like, well, we think that we might ask some questions about depression and anxiety, probably some on pain, but we don't know what else. And so let's see what comes up. And so we sat there discussing after the interviews, and it was just sort of cool. My biggest regret is if you've ever been to Houston, we have absolutely no good pizza here. So like the best we could do, it's terrible. I'm a New Yorker, and it's like I know. I see Cindy's response. It's like she hears me. So we're sitting there with like Papa John's, the best that we got, and we're talking about, okay, well, what do you hear? What did you think? And then piecing together what were some of the things that we want to do, and then asking our colleagues, people who are in this space, what do they reflect on? And that iterative process that really engaged people and their voices was really neat to get some of these constructs at play. And so I was very proud. This is a little bit nerdy. We had 302 adults come on through. Two of them ended up, we couldn't use their data for various reasons, but the goal was to be able to say to NIH, we exceeded our recruitment, which we did. Um, and again, broad topology. It was a predominantly Caucasian cohort of folks, and 43 young, which to me is like a baby. A little bit more, well, a fair bit more gender, female dominated. And then these were some of the things that we ended up asking about. So again, some of it we thought about with depression, anxiety, pain and disease perception, demographics and so on. But there were a lot of other things that came up. For example, the role of community support or religion was a big one. We heard other people talk about positives of coping, like if you had a partner who was really there for you, supporting you, helping out, or on the flip side, how sometimes it was just difficult, whether people experience themselves as a burden or they were concerned about being evaluated because of any sort of need. We heard about people describing kind of body image and sexual health aspects, and so that was something among our adults that came up a fair bit. Among our older kids, they talked a lot about dating, and what challenges or what sort of holds ahead for them. And then a big topic was sort of the medical experience. And one of the buffers or protective factors that we heard quite a bit was collaboration, and medical choices, discussion of options, as just massive. Whether or not the interventions ultimately were going to be successful, it was that team approach that I think many people described as important. And then we heard a few other aspects, and one of the things I'm sort of interested in just broadly is, like what differentiates someone. For example, you could have two people who are exactly the same, and one of them is able to do this much, and one can do that much. And so this is some random vague space, but like, what explains why those people differ? Why someone pushes through despite a lot of pain. And so we thought a lot about this and went to the literature. And some of the concepts that we ended up looking at were things like, grit, willing to kind of accept things as they are, and then move forward. A sense of self-compassion is a big one. And one of our colleagues, Marie Eve Robinson, is really an expert in this. And we spent a lot of time thinking about it and talking about it. This is a way of potentially being helpful, and something that, if we have a chance for the next cohort, we'll hopefully be looking at even further on an intervention level. And so we wanted to look at these as sort of moderating or modifying variables in relationships. So we met with a statistician Monday. For me, it was really neat. He was one of my old students who's now a professor at Harvard. And I have to admit, I was sort of like a proud father, just amazed at listening to him talk, stats mumbo jumbo. But these are like really, really rough. What we were just hearing from folks is, are pretty high rates of depression and anxiety. There's a lot of overlap in these two groups, but some that were sort of falling in one or the other. A fair bit of suicidality. This is probably a little bit higher than what we would expect in a population of people without OI. But a fair amount of lifetime history of suicide, either kind of thoughts or attempts. Um, and and then some of the data analytics that we really we're sort of seeing is, it is really this kind of concept of a burden. And not for everyone, but especially for younger people as they're trying to individuate from parents, or from others. I think that was something that a lot of people would describe as coming up, and and was also associated, not surprisingly, with the experience of pain as well. So this is one thing that right now we're still working on, kind of getting into final form for a paper. But these are a few of the papers that we're working on right now. Now, one of the things that isn't within this list is that we work a lot with medical students and psychology students, and one of the parts I dig is, how do we take someone that never considered a career in OI and get them really excited about this, either on the physical, the health side, or the psychological health side. And so we have a whole cadre of young people with much more energy than I have, working on some of these things. Now, any project is a team endeavor, and there's so many people that we owe gratitude for. Most importantly, really are the many people that open up their lives for us. It's hard to do, and it takes a lot of trust, and for that, we're massively, massively grateful, because it took that in order to be able to get some information out that hopefully will direct us in the next step. And then the OIF, because there's no way we ever could have done this without the support or partnership of that. I'm my biggest fear, besides being re-enrolled in college and having Geology 101, that's the nightmare I have. Someone described it to me the other day, and I'm like, yes, like we have kinship. But my other biggest fear beyond that one is that I always leave someone off this list. So if I did, believe me, we know, we acknowledge you, appreciate you, and I'd be remiss on that, and won't blame my team for that one. But an incredible collaboration across multiple institutions, countries, areas of expertise, as well. All right. Oh, and then I truly have no life, so don't hesitate to email me if questions come up that you prefer not to ask here. Give me a little time, but that's my job, is Zoom and email. Um, pretty much. Although you couldn't tell from the Zoom stuff with that fumbling of the slide set.
Uh,
Next time I'll do it.
Dr. Storch, thank you so much. This was fantastic. It really highlighted that there is so much happening in the space. And I mean, I think I speak for everyone. We're just so happy to have you and your team working on this. And I mean, by just all the sheer amount of studies and manuscripts you covered, you definitely have a life and you're very busy. So don't sell yourself short there. But so while folks are thinking about and typing in any questions they may have, I have a few questions that I wrote down for you that I'm going to just jump into actually. So one is actually you brought up before that anxiety is this prevalent thing and it's being talked about in multiple papers that are going to be coming out soon. I saw that one specifically mentioned post-traumatic stress. And one question I have is, so for me, I've worked now at the OIF since 2018. So for, you know, those years are climbing. And since my very first weeks working at the OIF, talking with community members, other folks with OI, people have been talking about their own PTSD. And it's kind of a term that, particularly in the community, will get thrown around a bit, and understandably so. This is I think the first time I've ever seen it mentioned in writing in a academic setting like this. Do you feel like, from what you're seeing in your interviews, it is post-traumatic stress disorder? What you're saying?
Great question. And I, a different way of thinking about it is it post-traumatic stress or disorder? And the reality is, I don't know that matters that much. And so I've done a lot of work in with children with trauma, and this is, oh my God, I think this is where I lost all my hair because they would be as young as 3, and they would have these awful, awful things happen, whether it was accident or seeing someone get shot or whatever. And what we always did was we really focused on the symptoms. So we would call it post-traumatic stress symptoms because it almost didn't matter if it crossed this arbitrary line that human beings made that calls it a disorder. So were you experiencing stress related to some traumatic event? Was it disabling? Was it upsetting? And and so I bring that up because I think if you take out the disorder, what it does is it allows us to recognize that a lot of people have had some difficult stuff going on, and or difficult experiences, and that can induce a lot of distress, that may reflect PTSD, whether it's nightmares, hypervigilance of things happening, or avoidance of old triggers. And the short answer is, yeah, we saw a lot of that. Now, the flip side, and I'm not a Pollyannish guy, but I always like to sort of juxtapose, like, well, 30% of people were anxious, let's say. 70% of people weren't. Um, and so what this also says is we had a very specific cohort that's had a lot of stuff happening, and yet the resiliency was actually pretty amazing when you reflect that way. And I think it, while we were seeing a lot of people with these elevated, post-traumatic stress concerns or anxiety or depression, we're also seeing a lot of people who were doing outstanding. I also think, and this is the last thing I'll say, we when we open up this call, we probably got some people who are really motivated to share experiences, and to be fair, it may have been even skewed to those that were endorsing a therapy history or past whatever. So just being acknowledging that, and that maybe these rates are even a little bit higher than if we just took 1,000 people with OI who we could sort of pick them out without advertising. Who
Yeah,
knows? But yeah,
interesting. Thank you.
yeah.
Um, on a kind of related note, uh, for you, what were some of the most surprising or unexpected findings from all of the work you've done so far in this field?
Mhm. I think the concern about parents being reported to DCF was one of the more shocking ones, and some of the challenges that some of the parents described.
Yeah,
That that one that one was heartbreaking, actually. And I think the challenges of explaining in the ER, no, here's what's going on, and and how parents were having their child's medical records with them to sort of buffer against that, or protect against that should it happen. I think that for me was probably one of the bigger ones. Some of the other stuff we sort of expected. So when originally meeting with Tracy, she's like, you're gonna love this community, and really sort of the robustness, the strength is gonna come out, and so that prepped us for these interviews and hearing stories, but hearing the resiliency. So that was awesome. Um, and then another impactful thing, but not so surprising, was the difficulty accessing care. And and if you were in a city, there are challenges with that, but it was easier because you had different medical resources perhaps better at your disposal. But if you're in a rural area, that in and of itself tended to be a big challenge. And again, things to be expected, and I don't think those are specific to OI, but hearing that was impactful.
yeah. Um, I'm kind of curious. So particularly in the interviews, I'm thinking particularly for the stage or phase one, but I guess it could be the others as well. When you're interviewing caregivers and clinicians versus people with OI, so adults, children, teens, were you seeing differences in how caregivers and clinicians talked about or described the mental health needs of people with OI versus how people with OI talked about their mental health needs?
Mhm. Let's see. Another good question. Um, the kids, the kids were hysterical. I'm a child psychologist. Like I just sort of like that kids in general. We have a similar maturity, especially the 15, 16-year-olds. But for a lot of them, it was just like, yeah, like, come on, let's get going. Um, and um, and and whereas their parents described a lot of fear, and I think parents of kids without OI have fear. I when I work from home, I see my daughter drive out the driveway, and I'm just like, oh God, what's going to happen there? Um, but uh, but but I think the parents were really describing. I mean, sort of an element of trauma in place. Like, is today going to be a good day, or can there be some challenge that comes in? And parents also had a sense of the future that differed, especially from the younger kids, and what might be challenges, how to set their children up for challenges. And then the transition age, while we didn't have a lot of kids or caregivers of 16, 17, 18-year-olds, that was something that parents were describing is what's sort of next when I'm not there, making sure everything's cool. Um, Clinicians, we were fortunate that our clinicians were OI specialists, so they got it, and I think they were describing things quite similarly to the adults that we were talking to in terms of needs, in terms of access, specialized access or personalized access. On top of that, pain management, behavioral health management. Um, if anything, a difference that I saw, uh, and I think this speaks to the team in general, you know, it's always, as a psychologist, it's always funny how when you introduce psychological concepts to docs that may not have been thinking so much about this. And I think our group thinks a lot about it, and now they're thinking even more about some of those behavioral health concepts. So, things like assessing for depression, anxiety, and then what do you do if someone endorses that?
Mhm.
Um, so I actually think that ended up being a really good series of discussions that we had of, hey, like you can manage this. It's okay to ask these questions. And if someone says, yes, I feel sad, okay, here's a few things you can do. Uh, but yeah, I think the kids and their parents were probably the biggest difference.
Gotcha. And that kind of follows some of the things we anecdotally see with our own just private conversations. Um, so I see we have some questions from the audience. One is from Tracy Hart. Can you explain why publishing this information is so important?
Mhm. One of the projects that I am so hopeful we get to do is a mindfulness-based self-compassion intervention, where from the comfort of your home, hopefully you have better pizza than we do. You get to learn skill set to deal with with pain, with anxiety, discomfort. Um, and the basis of saying this is important, like we need to intervene, is establishing that it's a problem. And if we can't get these data collected and then out there in the public, then there's no problem upon which to say, we got to do something. And so people's involvement allowed us to do that, and have allowed us to be competitive in that pursuit of continued funding in order to intervene. I think the other is also thinking of what do we do from that. So it's not just intervention, but it's recognition. Um, you know, I it's I would say at least once a day in of one of the areas I work in. So OCD anxiety is another. I do a lot in autism. I do some in trauma. Um, I get an email from someone that asks me a question, whether it was about study or whatever. And every time I get one of those, I always spend whatever time to respond, because in my mind, I sort of think of this phrase, if you help one person, you help the world. And it's like if you teach one person, then you teach the world. And I don't mean that in a narcissistic way. What I mean is like if I can teach someone to do this, and they can teach someone else to do that, and they've touched this many lives, and that person's touched that many lives, it starts having this compounded effect. And so that I think is such a big deal of being able to get that information out there and accessible to individuals who are in, rural North Dakota and have one patient with OI, and they get online and they find this information, gives them access to ideas or concepts. So I think that's another piece, how we disseminate that information and really change the standard of care, or at least understanding.
Yeah, thank you. Um, so I see this other question here, and I think it's a very good one, which is, are there any studies regarding mental health of siblings who without OI or in these families that are, not every child has it. I think sometimes like the term I've heard is like, like the glass child, meaning like
Mhm.
you see through them to the needs of the quote unquote like more needy child in this case, in our case, the child with OI. Is there been any work on this topic?
No, it's a superb question and a real challenge. I In OI there have not been. In other chronic illnesses there have been quite a few, like diabetes is a prime example. It's interesting what the findings sort of suggest for a lot of kids, a lot of this unaffected siblings, they do great. And it develops a sense of resiliency, of protecting their sibling, of being kind of a partner in this. My sense is that, some of what explains why the ones that do well is this, it's just sort of an innate, compassion, and, that's probably within the family context and so on. I think some of it is when parents, recognize that, well, we may need to spend more time with Joey, but we're also going to make extra time with Janie, as well too, and have special, split up duties, or have a special sort of day, or bring in a great uncle who's just a lot of fun, or whatever it is. And and then and so I think there are challenges and stressors for the unaffected sibling, but there's also this potential to sort of be uh, foster resilience and foster empathy as well. But I think, Bond, this is one of those things that if we were, able to, keep nerding out, like this would be a huge one to
Mhm.
really sort of understand. And there's again a lot of models and other conditions that can kind of provide information about how we might look at that or what might be some of the areas that we consider.
Yeah, absolutely. Um, One other thing I'm thinking about is so you had talked about previously about like the importance and role of publishing work uh, like this. I want to ask specifically like from the findings you're getting in all the various manuscripts, uh, like how might the findings, and I'm not sure if this is too soon or not, but are there ways in which you could see the findings influencing how clinicians approach the care for children, teens, and adults with OI? And kind of the second part of that is, are there certain interventions that maybe already exist or supports that could be most beneficial for care for people with OI?
Mhm. Um, so I think some of the findings that so I think the first sort of round set up the framework for here's why something needs to be done. Um, the I think that the perspective that aim to is that's like I don't know, like we planted the seed and just sort of watching it grow and
Yeah.
slowly going to get there. And but that aim three, that I think I'm excited about really what we're going to be doing, which is looking at what are those modifying factors. So one of them that is, I think, going to come out is that sense of self-compassion. And self-compassion is one of these areas that you can actually target and help people develop more and more of. And if you can do that, you can potentially help, change mental health outcomes among those that sort of need it, whether it's, linked to pain or anxiety, depression. But the idea to that is, it's a Michael, you're wearing glasses. I'm wearing contacts. I think if I took mine out, I could see that there's humans here, but that's about it. I'm so
Mhm.
blind. Um, but it's like when people are in a funk or they're really uncomfortable, they end up seeing the world in a more negative fashion. And so the whole idea here is to almost train to clear off the glasses, the fog from the glasses, or pop those contacts in and see a bit more objectively. And so I think that's something that can have immediate tangible benefits, but that would derive directly from these data in terms of care. I think the other part is that, or the other part to your question is what's out there already. I think we have good interventions, whether it's for things like depression or anxiety. Or pain. There's some like effective behavioral and or pharmacological interventions that can be helped, that can be helpful. Now, one of the things we have to do, which is again my hope for the next couple years, is take these findings and then bring home sort of a almost like uh, tips, Q&A or tips and tricks, whatever it is. So how do you take this treatment that is developed on average Joes, and what would be considerations for how do you personalize this for someone that's experiencing OI or chronic pain? You know, it's not in the psych world. It One of the challenges is that if people develop therapy, let's say, sometimes they'll want to develop it for like this really narrow cohort of human beings. And the problem with that is while it might be perfectly attuned, no, there's no uptake to it because no one's going to sort of pick up that one thing and just do that one thing. So if we're able to give kind of guidelines for how do you personalize some of these things that more people are doing, I think that's where we can start addressing some of the access issues. And that's one of our next goals.
Yeah. Thank you. Um,
Hey,
So,
Michael,
oh,
this is Tracy. I'm sorry. I have a quick question.
Yeah.
Hi, Eric. Um, you mentioned words like resilience and grit and those kinds of words. Is there a scale to measure that, or how did you even say, okay, this person's resilient or this person has grit? I hear those words and I just wonder how
Hmm.
you identify that.
Yeah. So the if anyone if anyone here has done this battery, um, it was long, it was painful. You sit on Zoom, which as an aside, we did only because whenever you have questionnaires missed, it makes our statisticians really like sort of irritable because they have to deal with missing data. So when I showed him our battery is like beautifully clean, he was pretty excited, which makes me he probably has less of a life than I do. But to your point, Tracy, the way that we did it in this study were just questionnaires. So there's a questionnaire that focused on hardiness, which I sort of think of as grit. Um, and then another one on resiliency, and then other ones, whether it's depressive symptoms or sort of sense of self-compassion or so on. The challenge with some of those scales, let me phrase it. The challenge with psych in general is that we don't have blood tests. Our imaging doesn't do anything to define a psych condition. Um, and and that sometimes the way you see the question is based on how you see the question. The way you respond to the question is how you see the question. Um, so there are challenges in the way that we assess things overall. We had hoped, as an aside, we didn't get a great score on this, but we're doing some work in computer vision or effective computing where you look at people's face, like facial affect or their muscles when they move, when they smile, or my kid said I had a 17 head, which I thought was a little excessive. It's more like a 14, maybe 13. But like you go like that and your muscles move, but you can use sort of that technology that your iPhone uses when it unlocks by reading your face to do stuff like read affect or read pain responses. And so the goal of that is to try to not just have questionnaires or interviews, but to have these sort of objective, quantifiable behavioral constructs that can get at some of these other things, maybe not grit or so on. But that's how we did it. If we for example, to Bon's question or comment, if we looked at siblings as just one cohort, or we ever did this project or a similar project in kids, we would get parent reports, the kid reports, of course, a sibling report of their own things. So you start getting some sort of triangulation of different perspectives on whatever the construct is, whether it's grid or so on. But here, specifically to your question, Tracy, it was asking people about their perceptions of constructs that have been validated to sort of align with resiliency or grit or anxiety or whatever.
Thank you.
Yeah, yeah. Thanks for raising that.
so my sort of kind of last question is really just what do you think the next steps are? And you've talked about this a bit for the well-being study and the work that you discussed here. I guess this is kind of that phase three.
Well, so I will say my attempt at buying a €1 house in Italy was foiled because my son made rowing nationals and it was exactly the time I was going to go. So that disaster is is not going to take place anytime soon.
Mhm.
But it seemed like a great idea to me. So because of that, and yeah, I won't be sitting in Italy writing papers, which is sort of my dream. What I think we hope to do are several things. And so you know, I I hopefully we have a little bit of luck on our side, or a little bit more stability on things. So the first and most immediate is finish writing papers. And I think Tracy's early point is key. Like if we don't establish the problem, we will never be able to get support to then address the problem. And so I think that that's sort of our motivating factor, is we want people to understand what's going on. Again, that phrase, the good, the bad, and the ugly. We want it all out there, so that we can sort of change, influence how we see things. Second, and this is what I meant about with a little bit of luck, is we're really hoping to be able to engage in this, for adults, mindfulness, self-compassion, online trial. And our hope, if we're able to continue with the BBDC study, is to really have a large trial where we're looking at, is this an effective approach, for addressing some of the concerns raised, and then why it works, why is it effective, um, and um, and so that's, I think, a next step. Um, from there, beyond that, is to try to get another generation of psychotherapists involved and excited. And, with the hope that I get that €1 house, somehow learn how to build things, so I can fix it up. And then, eat pizza, and pasta in Italy. But if it doesn't happen, how do we have, those young people really sort of going out and disseminating information about, understanding clinical issues or treatment or so on. And then I think, maybe before that even, is sort of that sort of tips and tricks, so to speak. Like, how do you take something that's been out there, let's say for depression, like a good treatment for depression is called behavior activation. How do we tailor that? Behavior activation is kind of what it means. Like, how do you activate yourself behaviorally? Well, maybe that's hard. Maybe you have to have certain considerations, and so thinking about that as a resource would be another piece. Yeah.
Great.
Oh,
Okay.
and
And actually, we got two quick late questions, but they're I want to address them while we still have a few more minutes. So one person is asking, particularly are there any studies regarding the mental health of parents? And if the parent does not have OI, and how that impacts the child with OI, and how they can either trigger each other and spiral down, or help each other with resiliency without ignoring the what each other is experiencing. So I think that's an interesting question. How is the mental health related of the two?
Mhm. Every couple is. I'll say a few things. So we didn't dig into that topic too much, and it's Laura's point's a superb point. Like that right there is a whole nother set of interviews, and discussions, and whether it's young people, whether it's parents of young people versus older people. We with adults who were in a relationship, I mean, there were some challenges, described, and there were a lot of great, I mean, wonderful aspects, that would come with any good relationship. Some of the challenges involved, an array of things, whether it was, sort of, burden on one, especially if they didn't have OI, relative to the other. And that went both ways. The person affected sort of being concerned about, their contributions, or not fully doing their part. Intimacy was another, that came up with some regularity among our adults, and just medical needs, too, and so on. So those were some things that came in. I think with kids, my hunch would be that is sort of a strong parenting alliance was critical. And how do you make sure that you're on the same page, that you're, hearing the other person, and valuing them in their role as a parent, as well as their own emotions, but also making time for the relationship. I think my hunch is that those would be some variables that are associated with more positive outcomes. And on the flip side, I think when there's sort of that divide, or that gulf, and when it increases, that's where we would see some problems happen. But Laura's point's excellent. And that's someone's dissertation right there.
Absolutely. Thank you very much. And then I see one last question here about would you be interested in speaking at a conference? And actually, for that, I'm going to put your email in the chat again. And if anyone wants to email Dr. Storch, I put it in the chat here before. It was also in the presentation, but before. He welcomes anyone to reach out to him directly. Only for the sake of time, though, we are going to have to end today's session. Dr. Storch, thank you so much for taking the time to talk to us, explaining the work being done with the OI Wellness Study and all of the various findings your team is getting. As always, it is a pleasure to talk to you. Thank you so much.
No, thank you guys so much. And really don't hesitate to reach out, email, and hopefully next time in person. But thank you all for your time and your contributions, thoughts, and opening your lives. So, all right. Have a
So
good night,
much.
y'all.
Have a good night. Bye.